Hello and welcome. My name is Garnet Gilmore. I'm the Director of Marketing and Sales at Warwick Forest, your premier sponsor for the Lifelong Learning Society. Today we are filming in our pool room, which holds our indoor saltwater heated pool. Currently the pool is at 90 degrees, nice and cozy, and it's great for doing water aerobics, swimming laps, or just relaxing. I'd like to introduce the speaker that's going to be joining you today, Dr. Sharma. Dr. Sharma earned her medical degree at Medical College in Nepal. She completed a residency in internal medicine, followed by a fellowship in pulmonary and critical care medicine, both at Staten Island University in New York. Dr. Sharma is board certified by the American Board of Internal Medicine. Drawn to caring for patients with lung diseases and critical conditions, Dr. Sharma brings the unique combination of clinical expertise, focus, empathy, and compassion that is so important for these specialties. Healthy communication is key to her practice as she works hard to earn her patients' trust and satisfaction. Dr. Sharma's utmost priority is to provide the best, most up-to-date care while facilitating informed decisions at every step. Dr. Sharma was born and raised in the mountains of Nepal. She and her husband, an infectious disease specialist, have one daughter.
Good morning. You guys can hear me?
Yeah, I got mine on mute, so I won't be able to. They will say something in the chat.
Okay.
Tilt it down a little.
Yes. Okay, great. Hi, my name is Dr. Sharma. I primarily work in Newport News Pulmonary Clinic. I also go to Williamsburg Pulmonary Clinic. Today I'm presenting asthma. I chose this topic because I have been practicing in Virginia for 2 months now, and I have a lot of asthma patients. And I have seen that there are many patients that have uncontrolled asthma. So I just wanted to give you what is asthma and how to control it, what is the pathophysiology behind asthma, so you guys have a basic understanding what asthma looks like. So asthma is important because asthma takes a lot of money from the healthcare. The problem with asthma is people come with exacerbation, and these exacerbations, to control these exacerbations, is very costly. So we actually work to decrease this exacerbation because it's costly to patients' health and it's costly to the healthcare too. Now, what we'll discuss today is the physiology behind asthma, how to diagnose it, what are the different types of asthma, what are other conditions that might be associated with asthma, what can mimic asthma, what's the severity of asthma, how can we establish a care, and how can we do a stepped care in asthma, how to treat exacerbations of asthma, and the novel treatments that are being introduced to control uncontrolled asthma, for the people with severe asthma, what are the novel treatments that's available. So these are the topics that we'll be discussing on. So usually asthma is a childhood disease. These children are either genetically susceptible or they have these environmental challenges, and that's why they are prone to have asthma. We call this atopy. These children, whenever they are introduced to pollens or cats or roaches, they have allergic stimulus in their lung and give them the symptoms of asthma. So asthma is usually a childhood disease. But what we are seeing now is asthma is being shifted to adult disease. And why? Why is this a problem? Number one is because of smoking, and number two, it's because of obesity. So these were the two main problems that asthma is now being uncontrolled, and asthma has shifted its clause from children to adult. It has been seen that atopy, which means that you are very susceptible to any kind of allergen, is associated with higher socioeconomic status. Why? Because that's what I have, that's what I have seen, that people with poor socioeconomic status, they are exposed to many allergens when they are children. And the more you are exposed to the allergens as a child, you will develop a sensitization to those allergens. And as an adult, maybe you will not develop asthma. People with high socioeconomic status, they're usually confined to their, buildings, to their apartment. They usually don't, they don't usually go out with a lot of children. They are not exposed to many allergens. So that's why these children are more susceptible to have sensitization when they grow. That's why asthma has been associated with high socioeconomic status for some reason. I'm sorry. So I made this slide just to have a understanding what these allergens are doing to our body. So whenever you are, you inhale an allergen, or you eat something that's allergic, right? Or your skin is in touch with some kind of allergen. These allergens are taken up by the cells, and these cells produce a lot of cytokines, which we call cytokines, and inflammatory mediators. And these mediators start to degranulate all the granules in our lungs and in our airways. And these granules just produce a lot of inflammation, lot of mucus production. There is like proliferation of the smooth muscles that's present in the airway, and that gives you an obstruction of the airway, giving you wheezing, gives you cough, gives you shortness of breath. That's how the allergens are mediating asthma. Now, we found that there is something called non-allergen asthma, meaning that people are not susceptible to allergens, but they still have asthma. And these people were found that these people are being attacked by pollutants or by microbes, like viruses, like bacteria. These viruses, pollutants, or bacteria, they mediate a different kind of cascade in our body, and ultimately they just produce these chemicals producing inflammation, mucus production, the same thing as the allergen. So there are two types. One is the allergen, another is a non-allergen, and non-allergen people don't have the constellation of symptoms that allergen people have, like rhinitis or lot of polyps in their nose, or they have sinusitis. So sinusitis, rhinitis is more allergen. Non-allergen people just have asthma, and these people have that because they are being introduced to either viruses or bacteria, or they just are being introduced to pollutants. As I said, this diagram, it just shows how allergen asthma works, meaning that your body, it just is prone to some kind of allergen. It can be either pollens, it can be roaches, it can be mites, it can be dust, anything that attacks to your body, and it produces a cascade of inflammation. I will avoid this. This is all the cytokines, and these are all the inflammatory cytokines that's produced in asthma that gives you the inflammation. And the novel treatment that I will be talking about later, these novel therapies direct on these cytokines. They just stop these cytokines from being produced in our body. That's how we got these novel treatment for people with uncontrolled asthma, because they act on these cytokines that's acting in asthma. Now, apart from cytokines, there's something called leukotrienes. The same thing. These leukotrienes are also produced as a mediator in people with asthma. It increases the airway hyperreactivity. It increases edema of the mucosa that's lining the airway, and it increases the secretion in the airway. And the therapy that's that's very common in asthma is to stop the leukotrienes and cytokines. The leukotrienes inhibitor, I think many of the people have used it. We call it, the medicine is called Singular. I think many people know this, that they take Singular every day. What Singular does, it inhibits this leukotriene, which is involved in asthma. So asthma, in conclusion, is that whenever we are triggered, our body just produces the cytokines and leukotrienes, and these chemicals just give that wheezing and mucus production, edema of your airway, and you're just not able to breathe. Sometimes we misdiagnose asthma because asthma can mimic other conditions too. In children, it's usually because of either they had congenital heart disease or they have congenital dysfunction of their cilia that acts in the airway, or they have this congenital symptom called cystic fibrosis. But in adult, we can sometime, some disease can mimic asthma. Suppose number one is medication-related cough. Some people are taking those medicine that just acts, this gives symptoms like asthma. For example, if you are taking lisinopril, or you are taking aspirin, these medicines sometimes can give you same symptoms as asthma, and physicians is like, what's going on? And they see the medication list, and they get these medicine. When you stop it, your symptoms are more controlled. Also, other conditions like COPD. How to differentiate if a patient has asthma or COPD? The simple thing is ask if they were smoking or not. If a patient was smoking and he's wheezing, the most likely he has COPD. Now, how much do you have to smoke to get COPD? Some people just ask me, like, I have been smoking 1 pack, and I smoke 1 pack in 1 week, and I have been smoking for 30 years. Would that give me COPD? So they came with this number saying that if you have been smoking 1 pack every day for about 30 years, that means you have COPD. That is the number that they came with, that you have to smoke 1 pack a day for almost 30 years to get COPD. But said that, some people smoke less and they get COPD. Some people smoke like chimney and they don't have COPD. Why? Because these people are genetically susceptible to get COPD. Their parents had COPD, they just have bad genes, and that's why even with fewer smoking, they get COPD. Okay, so COPD can mimic asthma. Heart failure can mimic asthma. People with heart failure have fluid in their lung. And when you have fluid in your lung, you wheeze and you are short of breath. This can mimic asthma. Heart failure can mimic asthma. COPD can mimic asthma. There is something called vocal cord dysfunction, meaning the vocal cord in your neck is just not working, and it gives you episodic period of shortness of breath, and there is something called stridor, like this breathing pattern. It's usually not because of asthma, but your vocal cord is not working. This is a biggest mimicker for asthma, because asthma is also episodic. It also gives you wheezing. Vocal cord dysfunction is also episodic. It usually happens in females around 40 years of age, and they usually have anxiety as baseline, and the vocal cords don't work, and in episodes they get shortness of breath and stridor. So these are some diseases that can mimic asthma. Your primary care doctor would be treating you for asthma while you would have completely different diagnosis. So you just have to know that fluid in your lung, which is heart failure, COPD, even clots in your lung can mimic asthma. They can give you episodic shortness of breath. Vocal cord dysfunction can mimic asthma. So how to diagnose asthma? What are the symptoms that makes you lean towards the diagnosis of asthma. Number one, asthma is episodic. If a patient tells me, doctor, I'm always short of breath, or when I walk a flight of stairs, I am short of breath, this is not asthma, because asthma comes in episodes. People tell me there are days where I'm so good, and there are days where I can't just breathe. This is asthma. This episodic flare is associated with wheezing, with cough, with a lot of mucus production. The episodes is worse at night because the chemicals, they are more produced at night. So, if the patient tells me I cough at night, that might be asthma, or my breathing just gets worse at night, that might be asthma. But the problem with asthma is there is no one standard thing that I can do and tell you, oh, this is asthma, because the patient symptoms itself can point out if this is asthma or not. Okay. What are the things that decreases the likelihood that patient has asthma? If the patient is more than 50 years, then the likelihood that he has asthma is less. Because as I said, asthma is a childhood or a teenager disease. It did shift its clause from children to adult, but these adults are younger adults. If you're telling me that after 50 years you are getting shortness of breath, that might be because of your heart, or that might be COPD, or that might be clot in your lung, but asthma is less likely. Okay. Also, asthma is less likely if your shortness of breath is not improving on inhalation, the pump that we give you. If you use those inhalers and your symptoms are not improving, less likely that you have asthma. Okay. If your symptoms is associated with weight loss, less likely that is asthma. Now, there are few conditions where people can say, and I'm like, okay, you might have asthma. What are these conditions? Suppose people have rhinitis, sinusitis, polyps in their nose, dermatitis, because these are all allergens related. So I can say maybe you have asthma. So there are some features that increases the likelihood of asthma. There are some features that decreases the likelihood of asthma. Okay. I think the most important thing to do in asthma, to diagnose asthma, is number one, as I told you, the symptoms. People will tell me it's episodic. Doctor, it's episodic. I have a lot of wheezing, I have a lot of cough, but it's episodic. It's not always there, right? Number two, that a doctor will order to know if it is asthma or not is a breathing test. Okay, the breathing test in asthmatic people is normal. Now, why is the breathing test normal? You ask me, because as I said, asthma is episodic. If you do the breathing test when you don't have symptom, obviously the breathing test will be normal. So most of the people will have normal breathing test in asthma. There are only few people who have very severe asthma or persistent asthma. They have some degree of obstruction in their breathing test. Okay, breathing test is usually abnormal in COPD. That's how we differentiate between asthma and COPD. If your breathing test is very abnormal, more likely it's COPD. If your breathing test comes as normal, because asthma is episodic, maybe that's asthma. Okay. Now, as I said, that asthmatic people will have a good response with the inhaler. If you're using the inhaler, with the use of inhaler, your breathing does not improve, go to your doctor and tell them that your breathing is not being improved. Maybe this is not asthma. Because when you use the inhaler, right, and you do a breathing test, your breathing is a lot improved. That's how we make a diagnosis of asthma. On a breathing test, if you use the inhaler and your breathing test is like improved a lot, we can tell that this is asthma. If it is not improved, this is less likely asthma. I prepared this question but what this question is asking is, if a patient comes and you know, and she's telling me that, doctor, I have difficulty breathing, and your physical exam is normal, your breathing test is normal, everything is normal, and still the patient is like, doctor, I am short of breath, right? Now, since she's 32, since she is still young, how do I make a diagnosis that she might have asthma? So these people who first of all don't give me a good diagnosis of episodic period, they are like, I am short of breath, I am always short of breath, right? And number two, they are young, right? And number three, their breathing test is normal. So how do I make a diagnosis that this female might have asthma? There's something called a challenging test. We can challenge people to see if they have asthma or not. And now in this challenge test, what we do is we give these patients a specific drug. That drug will mimic asthma. Suppose I have asthma and I take that drug, my breathing test will be much worse. So that's how we can diagnose people who does not have all the symptoms and, you know, of asthma. We can challenge them and make a diagnosis of asthma. So, you know, you can, next time when you go to a doctor, you can ask them, listen, I don't know if I have asthma or not. What about a challenge test? They can challenge you and see if this is asthma or not. Now, there are absolute contraindication to challenge test. I wanted to include the slide so that people know what are the absolute contraindication of the challenge test. If you have heart attack or stroke in 3 months, if your blood pressure is not controlled, you have an aortic aneurysm, these are some contraindication that your doctor should not challenge you, okay? Now, I've included this test, question so that we understand which of the following concerning bronchoprobiotic test is more accurate, meaning that whenever you challenge people, which of the following can you see? And I'm going to tell you that if you challenge asthmatic people, there is almost no chance that the test will be negative. The test will be positive. The test is very sensitive. If you challenge asthmatic people, a susceptible patient, the test will be positive. So the test is very sensitive. I'll avoid this thing. Now, as I showed you in the in previous slides, that there might be 2 variants of asthma. Number 1 is the allergic asthma that we are always talking about. These patients have allergic rhinitis, the patients have allergic dermatitis, these patients have sinusitis, they are, you know, whenever they are exposed to certain kind of trigger, they get asthma. These people have allergic asthma. Now, there are certain asthma but are non-allergic asthma. As I told you from previous slide, these people are susceptible to viruses, bacteria. These are the people who smoke, and these are the people who are obese. And these are the people who have adult onset asthma rather than childhood asthma. Okay. Now, there is something called steroid-resistant asthma. So in asthma, the main treatment that we can do is steroid, because steroid decreases the mucus production, it decreases the reactivity of your airway, right? So when we treat asthma, especially severe asthma, we always give them steroid, prednisone. That's how prednisone is very famous in asthmatic people. When they take 1 pill of prednisone, they feel so much better. But some people take prednisone and still their asthma is not controlled. Why? Because these people are smokers. These people, you know, either have severe asthma, and the asthma is just resistant to steroid. Now, and these people are the one that we use novel therapies, the new therapies act on the inflammatory mediator itself. So the steroid resistant asthma, you have prednisone pills, your doctors give you prednisone pills every time. You take the prednisone pill, you feel somewhat good, but then your asthma is always there. It flares up again. What should you do? You can ask your doctor about novel therapies. Now, as I told you, there are few conditions that can mimic asthma, and this is the most important one. So this patient comes to me. She has every symptoms of asthma, right? But her asthma is just not controlled. I gave her every medicine to control asthma, not controlled, not controlled. Then I did a chest X-ray and a CT scan. She had something very concerning on the chest X-ray and CT scan. So whenever your asthma is not controlled, the doctor should dig in deep. Is there anything that's mimicking the asthma? Things that mimics the asthma. Number one is the mold. If there is mold in your body and the mold is just producing this allergy, that is not asthma. That is something called allergic bronchopulmonary aspergillosis. Aspergillus is a mold that's very commonly found in our environment, in our house. These molds in susceptible people, it's in their airway, and these people have asthma-like symptoms. It's just not controlled with whatever we do, because they need anti-mold medicine, antifungal medicine. Mold is a fungus, right? So they need an antifungus medicine. So your asthma, if it's not controlled with whatever medicine your doctor is giving, then you might have fungus in your lungs. The other thing that mimics asthma, so there are two most important things that can mimic. One is the fungus in your airway. The second thing that can mimic asthma is called EGPA. It's called Churg-Strauss disease. It's a autoantibody disease. When the same thing, your doctor have given you every medicine for asthma, still your asthma is not controlled. Tell them to do either a chest X-ray or a CT scan. This can tell you either if you have a mold in your body or if you have an autoantibody disease, which is called EGPA, that's mimicking like asthma. Okay. Now, how do we classify if the asthma is mild, if the asthma is moderate, if the asthma is severe? How would you know where your asthma is? The very important and the only thing that I ask people who have asthma is, how often do you wake up at night? If the patient is waking up more than 2 times in a month, it means that asthma is already persistent. If they are waking up less than 2 times in a month, their asthma is mild intermittent. So the nighttime symptoms is very important. If you're waking up more in the night, that just means that your asthma is more in severity. Number 2, I ask them is, how often did you use your inhaler? If the patient tells me, I am using my inhaler almost every day, that means your asthma is not controlled. Right. Number 3, I ask them is, how is the asthma interfering with the normal activity? If they tell me that I am severely limited because of my asthma, that means you have severe disease. So nighttime symptoms, how often do you use the inhaler? How is it inhibiting, limiting your lifestyle? Then the second slide is, how would you know that the asthma is controlled or not? Same thing. You ask yourself, how often am I using the inhaler or the nebulizer? If you're using once a week, it means your asthma is good. Your asthma is well controlled. If you're using every day, it means the asthma is not controlled, right? So how often you are using your inhaler, how often you are waking up at night. These are the most important 2 things that I always tell my patient. Write it in your diary. How often do you wake up at night because of cough or because of wheezing, because of shortness of breath, and how often are you using your inhaler? Because those 2 things will tell me how well controlled your asthma is. Now, I included the slide because I think this is very important. I don't think that many of the doctors understand this, that when you have asthma, when you are diagnosed with asthma, the most important treatment for asthma is inhaler that contains steroid. You can't control asthma without giving an inhaled steroid. Inhaled steroid is like Symbicort, like Brio, like Dulera, like Asmanix. These are the inhalers that contain steroid, and asthma will never be controlled if you are using non-steroidal formulations like just albuterol, Ventolin, ProAir. These medicines don't contain steroid. Ask your doctor that you need a steroid included medicine, a steroid included inhaler. Only then your asthma will be controlled. That's what I included in this slide. That's inhaled steroid, IHCS, inhaled steroid, like Symbicort, like Advair. These are the first line therapy for asthma. If you don't have inhaled steroid in your pump, your asthma will never be controlled. So this is a slide that tells us how do we step up treatment for asthma. Suppose a patient comes to me, he says, doctor, I have this wheezing or cough, and I get this maybe once in a month, right? So that means the asthma is very mild. Okay, this patient need inhaler only when you need it, meaning only rescue inhaler. They don't need a maintenance inhaler. They need a rescue inhaler. Whenever you have symptom, you use that inhaler. That's it. Now, if a patient comes to me and says, doctor, I have symptoms 3 times a week, that means the asthma is not controlled. These patients need maintenance inhaler, meaning that you have to use inhalation medicine every day, no matter what. If your breathing is good, use the medicine. If your breathing is bad, use the medicine. Your asthma will not be controlled on rest inhaler only. You need some kind of maintenance inhaler. That's how we step up in asthma. If the patient is mild, we give them as needed inhaler. If the patient is moderate, severe, very severe, we just increase the maintenance inhaler dose and we increase the steroid that's in the maintenance inhaler. You know, if the patient is moderate, we give them medium dose inhaler. If the patient is severe, we give them high dose inhaler. So that's how you step up in asthma. Low dose steroid inhaler, medium dose steroid inhaler, high dose steroid inhaler. This is the same thing that we talked about. Now, what are the novel therapies that I was talking about? What are the novel therapies, and what are the other things that we can use? These things are only used when your asthma is not controlled on maximum medicine. And this maximum medicine is that you are at highest steroid inhaler. You have maximum dose steroid inhaler and still your asthma is not controlled. What to do then? What should your physicians do, right? There are few options after that. Number 1, we can add something called Spiriva. Spiriva is another bronchodilator that can help in asthmatic people who have uncontrolled asthma. Or we can use the novel therapies. Now, what are the novel therapies? The novel therapies, as I said, eats up the inflammatory mediators like cytokines and leukotrienes. These are usually shots. The shots are, they are either IV shots or they are subcutaneous shots that you can use. Now, again, these medicine can only be used if your asthma is not controlled on the maximum steroid dose. Okay, your physician should just up the steroid, up the steroid, up the steroid, up the steroid. Now he has reached a plateau of the maximum steroid dose, and still your asthma is not controlled. Then only the shots count. Okay, and as I said, these shots are, number 1, they're expensive. Number 2, they can be only given in the clinic or hospital, because sometimes they can trigger another reaction to your body. So you can't have those shots in your house. So they are usually given in a doctor's office. And number 3, they help to control asthma in only those people who have used steroid and they are in maximum dose of steroid. Okay. Now let me just talk about how to control acute asthma exacerbations. So I usually what I usually tell people that always maintain a diary that says how often did you use your inhaler, how often are you waking up at night, because if you are getting worse and you are using your medicine and still you are getting worse, it just means that you're waiting for an acute flare-up of asthma. And when you have acute flare-up of asthma, you end up in ER. And when you end up in ER, it's just not a good sign. It just means that there's so much of inflammation in your airway. It means that now I need to give you IV steroid or oral steroid to continue your asthma. I can't give you inhaler steroid anymore because you have so much of inflammation. Asthma is a very dangerous disease to have acute flare-up. If a patient has acute flare-up of asthma, he sometimes may end up in a ventilator. So we want to avoid that, right? So that's why I always tell people, maintain a diary. If things are getting worse, always call us so that we can prevent the acute flare-up of asthma. Same thing, how to manage acute flare-up of asthma. These can't be managed at home. You have to come into emergency department or hospital because you need IV steroid for management of flare-up. And if you are not being improved in IV steroid, you might need a ventilator. These are the indications when we attach patient with asthma flare-up to a ventilator, meaning they have change in their mental status. They are just tired because of their breathing. They look very somnolent. Their breathing just gets worse. Their oxygen level is just decreasing. Their carbon dioxide level is just increasing despite us giving IV steroid. That means now you might need a ventilator. I spoke about the novel therapies. As I said, there are many novel therapies now available. I think the one that people are familiar is Xolair, Nucala, Frensco. So there are many novel therapies that are available. These novel therapies are shots. They're usually given IV or subcutaneous. You need a doctor to give them. You need a clinic or a hospital to get them because you might have reactions to the shots. And these shots are expensive. And these shots are usually used in people who have severe asthma and that's not being controlled with the inhaler. These are some names of the novel therapies that we use, and we use based on these studies because novel therapies have shown to decrease the exacerbation of asthma. They have been shown to decrease the hospitalization rate. Again, a different novel therapy, mepolizumab. It's very common nowadays. We call it Nucala. The same thing. These medicine have been associated with decreased exacerbation rate. Another novel therapy, Benralizumab, very common these days. We use in patients who have been maximized with the therapy and still not controlled, right? Now, the last thing that we can do in asthma people is something called bronchial thermoplasty. This is like I have done in maybe 2 patients. So this is a therapy that we can use in few patients that are just not being controlled. You use novel therapies, you use every kind of steroid. They still are every day. They're wheezing, they're coughing, they're always in hospital because of flared up of asthma. So what do? We can use something called bronchial thermoplasty. What this does is it passes a small camera into your airway, and there is like a heat radiation to the camera. It just burns up the extra mucus and extra muscles that are building up in your airway. It just burns up and it opens the airway. Now there are not good studies showing that this works. Wow, this works. I have used, as I said, I have used only in 2 patients. This is the last resort in uncontrolled asthma. We can use something called bronchial thermoplasty. And sometimes we are confused because sometimes people have asthma and they are old. As I said, that old people usually don't give asthma. It just decreases the likelihood that they have asthma. They might have something else. But as I said, if you are a smoker, you might have adult onset or old age onset asthma, and these people are usually don't get well with the steroid. They might need either antibiotic to control asthma. It was shown that if people are smoker and they have asthma at late age, they can have control in their asthma with the addition of antibiotic. The antibiotic is called azithromycin. Something that we can think of if your asthma is not controlled and if your asthma was diagnosed later on in your life. So yeah, I mean, now these are just some experimental therapies that they are just working on, but then it's not approved. These are the experimental therapies. Again, these are the people who have maximized their nebulizer or maximized their therapy in asthma. They're still not controlled. We can't give them shots because they're either allergic to the shots or something. There are some experimental medicine that's still being studied on. I don't have a good journal to base these studies on, but yes, there's some methotrexate they have been working on methotrexate, or they have been working on some antifungal to see if the patient don't have fungus, but to see just if antifungals can help them. But again, these are very experimental medicine. Do you guys have any question? Okay, so Mary asked me a question. To be clear, did you say should only need inhaler once a week? What if used 2 times a day? Non-smoker, 50-year-old. As I said, one inhaler is a maintenance inhaler. For example, Symbicort is a maintenance inhaler. You need to use your maintenance inhaler every day, no matter what. There's something called rescue inhaler. The rescue inhaler is used whenever you need it. So when a patient comes to me and says, "The doctor, I have used my rescue inhaler once a week," that means the asthma is well controlled. That is not a maintenance inhaler, it's a rescue inhaler. If the patient is telling me that I have used my rescue inhaler 3 times a day, that means it's not controlled. That's what I was telling you about. The maintenance inhaler, you have to use it every day, no matter what. It's the rescue inhaler that tells me if your asthma is well controlled or not. What about rhinitis? What is rhinitis? Rhinitis is inflammation in your nose, that you're always dripping your nose out. It's also allergic condition, rhinitis, meaning, do asthmatic have an increased risk of death with COVID-19? Okay. Very controversial topic, but yes, any patient or every patient who has some problem with the lung will have increased mortality with COVID-19, because COVID-19 is a lung problem. It gives to pneumonia. If you have underlying inflammation in your lung to begin with, then obviously yes. But as I said, it's not studied. But yes, we have found that people who have asthma, people who have COPD, people who have who suffer from recurrent pneumonias, these are the people who have bad COVID. Yes. Any other questions? Okay, thank you so much. If you guys have, as I said, uncontrolled asthma, you're suffering from asthma, please, you can visit me. I do in Newport News, and I also do in Williamsburg. Thank you guys.